The United States boasts some of the best hospitals, cutting-edge medical research, and world-renowned physicians. Yet its healthcare system is widely regarded as broken, inefficient, and unequal. Despite spending more per capita on healthcare than any other nation, millions of Americans lack insurance, costs continue to skyrocket, and overall health outcomes lag behind many other developed countries. This paradox raises an important question. What caused the USA to have such a broken healthcare system? The answer is complex and rooted in a combination of history, culture, politics, economics, and institutional power that has shaped American healthcare over more than a century. To understand why the U.S. healthcare system is so fragmented and expensive today, we must first explore its historical origins. Unlike many other wealthy nations that adopted universal healthcare systems early in the 20th century, the United States never embraced a government-led approach. Instead, healthcare evolved largely as a patchwork of private insurance, employer-based benefits, and public programs for specific populations. This unique path was influenced heavily by the country's cultural values around individualism, skepticism of government intervention, and a free market approach to services. In the early 1900s, most Americans paid for medical care out of pocket. Hospitals were small, community-based institutions, and medical care was relatively simple and affordable by today's standards. European countries, meanwhile, were experimenting with socialized medicine or national health insurance programs aimed at broadening access and controlling costs. The United States, however, resisted such reforms. The American Medical Association, AMA, a powerful professional group, actively opposed government involvement in healthcare, fearing it would threaten physicians' autonomy and income. They launched campaigns to label any attempt at government-sponsored health insurance as socialized medicine and a threat to American freedom. When President Franklin D. Roosevelt introduced the New Deal in the 1930s, expanding social welfare programs to address the hardships of the Great Depression, healthcare was conspicuously absent. Attempts to include national health insurance as part of the New Deal failed due to opposition from the AMA, private insurers, and business interests who feared the economic and ideological consequences. Roosevelt himself avoided the topic to maintain political coalitions. As a result, health insurance remained a private matter, tied to individuals' ability to pay or receive charity. World War II created new economic dynamics that shaped healthcare for decades to come. During the war, wage and price controls limited companies' ability to attract workers through higher pay. To circumvent these limits, employers began offering health insurance as a fringe benefit to attract and retain employees. This practice was further solidified when the government exempted employer-sponsored health insurance premiums from income tax, making it a highly attractive form of compensation. Over time, this led to the development of the employer-based health insurance system that now covers the majority of working-age Americans. While this system expanded insurance coverage for many, it also tied healthcare to employment status, leaving part-time workers, the unemployed, and those in precarious jobs vulnerable. The reliance on employer-based insurance created significant coverage gaps and contributed to the rise of a fragmented system with varying levels of access depending on job type and sector. Furthermore, this system created perverse incentives for employers to control costs, which often meant limiting benefits or pushing workers into plans with high deductibles and copays. The 1960s brought important changes with the creation of Medicare and Medicaid in 1965. These landmark programs provided government-funded health coverage to elderly Americans, the disabled, and low-income individuals. Medicare, funded federally, offered near-universal coverage for seniors, while Medicaid, administered jointly by federal and state governments, served the poor. Although these programs were significant milestones, they did not create a universal safety net and instead added additional layers to an already complex system. Medicaid eligibility and benefits vary widely by state, leaving many low-income Americans uninsured, particularly in states that chose not to expand coverage under later reforms. As the 20th century progressed, the healthcare system grew increasingly privatized and market-driven. Hospitals, insurance companies, pharmaceutical firms, and medical device manufacturers became major corporate players with vast financial resources and political influence. Healthcare evolved into a multi-trillion-dollar industry with complex billing, marketing, and lobbying operations. powerful industry groups worked to shape legislation and regulation in ways that protected their profits, often at the expense of affordability and access for patients. One of the most consequential outcomes of this corporatization was the rise of administrative complexity and inefficiency. Unlike simpler systems in other countries, the U.S. healthcare sector is burdened by thousands of different insurance plans, each with its own rules, billing codes, authorizations, and reimbursement procedures. Hospitals and physicians must devote enormous resources to navigating this maze of paperwork. Studies estimate that administrative costs may account for up to 25 or even 30% of total U.S. healthcare spending, compared to roughly 10% in countries with single-payer or streamlined systems. This bureaucracy diverts funds away from patient care and contributes to higher overall costs. Another major factor contributing to the broken system is the absence of effective cost controls. In most developed countries, governments negotiate prices for drugs, medical devices, and hospital services. They regulate fees, limit unnecessary procedures, and emphasize value over volume. The U.S., by contrast, allows providers and manufacturers considerable freedom to set prices. This has resulted in wildly variable and often exorbitant costs for identical services, depending on geography, insurer contracts, and market power. For instance, a knee replacement can cost tens of thousands of dollars in one city and a fraction of that in another. Patients often receive bills months after treatment with little transparency about charges beforehand. The pricing issue is compounded by the dominance of the fee-for-service payment model. Doctors, hospitals, and specialists are typically reimbursed based on the number and type of services provided rather than patient outcomes or cost-effectiveness. This system encourages overutilization, excessive testing, procedures, and hospital stays that drives up expenses without necessarily improving health. While there have been efforts to shift toward value-based care, these remain limited and fragmented. Pharmaceutical pricing is another notorious problem. The United States pays by far the highest prices globally for prescription drugs. Factors driving this include a complex patent system that grants extended exclusivity to drug makers, a ban on Medicare negotiating prices directly with pharmaceutical companies, and aggressive industry lobbying that blocks legislation aimed at reducing costs. As a result, patients face skyrocketing medication costs, contributing to financial hardship and medication non-adherence. The fragmented nature of insurance coverage also leads to significant disparities in access and outcomes. Millions of Americans remain uninsured or underinsured. Before the Affordable Care Act, ACA, in 2010, nearly 16% of the population lacked insurance, including many working adults and their families. The ACA made important strides in expanding coverage through Medicaid expansion and insurance exchanges. Yet millions still fall into gaps due to cost, eligibility restrictions, or state-level policy decisions. The uninsured often delay care or avoid seeking treatment, leading to worse health outcomes and higher emergency room usage. Health inequities are stark along racial, socioeconomic, and geographic lines. Minority populations frequently face systemic barriers such as fewer nearby providers, language challenges, and implicit bias within the health system. Rural areas struggle with shortages of primary care physicians, specialists, and hospital closures. These disparities exacerbate the broken system's effects, contributing to lower life expectancy and higher rates of chronic disease among disadvantaged groups. Political polarization has played a significant role in preventing comprehensive healthcare reform. Health policy has become a highly contentious and divisive issue, with debates often framed as ideological battles between socialized medicine and free market solutions. This polarization has hindered bipartisan efforts and led to repeated legal challenges against programs like the ACA. The highly fragmented nature of U.S. governance, with competing federal, state, and private actors, further complicates reform efforts. Another hidden cost driver is the culture of defensive medicine. Physicians, fearful of malpractice lawsuits, frequently order additional tests and procedures as legal protection rather than clinical necessity. This adds substantial costs without clear benefits for patients. tort reform has been proposed as a remedy but remains politically challenging. Despite these flaws, the U.S. healthcare system has notable strengths. It is a global leader in medical research, innovation, and specialty care. American hospitals and universities pioneer breakthrough treatments and technologies. Top-tier physicians attract patients worldwide. However, these centers of excellence often exist alongside gaps in basic primary care and preventive services, contributing to fragmented and inequitable outcomes. The complexity and entrenched interests of the U.S. healthcare system make reform exceedingly difficult. Proposals range from incremental improvements to sweeping single-payer systems like Medicare for All. The ACA's approach sought to expand coverage while maintaining the private insurance market. While it reduced the uninsured rate substantially, it did not resolve fundamental issues like cost containment or administrative complexity. To truly fix the system, experts argue, the U.S. will need to address multiple interconnected problems simultaneously. Expanding universal access, controlling costs through price negotiation and regulation, simplifying administration, shifting incentives toward value-based care, reducing disparities and reforming drug pricing. Progress will require political courage, stakeholder cooperation, and public engagement. In summary, the broken state of the U.S. healthcare system is the result of a century-long series of decisions shaped by cultural values, political battles, economic interests, and institutional power. The reliance on employer-based insurance, fragmented financing, lack of price controls, influence of powerful industry lobbies, and political polarization have created a system that is expensive, inefficient, and deeply unequal. Understanding these root causes is essential for charting a path toward a more equitable, affordable, and effective healthcare future. As Americans debate the future of their healthcare system, the question remains: can the U.S. overcome these systemic barriers and create a system that delivers quality care for all without bankrupting families or the nation? The answer will profoundly shape the health and well-being of millions for generations to come.